last speaker for this session, we've got Kylee Trevillion, and she's presenting on evaluating models of health-based independent domestic violence advisor, or IDVA, provision within a maternity setting.
Lovely, thank you. Thanks very much. Thank you, everybody. It's lovely to be here. So, yes, we do have an acronym for our study to make it a bit snappier. So we're calling it the RIVA study. And what we're wanting to do is look at the implementation of a domestic abuse advocacy program in hospital settings, and particularly looking at its effectiveness in maternity settings. And I'll outline very briefly, because I don't have much time, why we're focusing on those settings in particular. So I just wanted to start by briefly showcasing our team. We're working with a lot of ARC partners. I'm based with the South London ARC, but we're working with partners in ARC West, in the Southwest Peninsula, in the Pen Arc, at North East and North Cumbria. Many of you will know Ruth and Judith, and also, other colleagues. We're working with a great implementation scientist and his team in Yorkshire and Humber ARC. So very briefly, I'm just going to kind of highlight some of the key points of why this is an area of interest and an important focus. We know that domestic abuse is common across the globe, and it is disproportionately affected by women. Around 1 in 5 women may experience domestic abuse in the pregnancy period, and we know that it increases the risk of physical poor outcomes for the women with regards to preterm births or low birth weight of the infant, and also increases the risk of mental health problems. With respect to the impact on children, we see a strong association between children exposed to domestic abuse in the home and poorer physical and mental health outcomes and low academic achievements. But what we're thinking with regards to the pregnancy period, and why that's a critical time to think about prevention and intervention, is that pregnancy is a time where women are in repeated contact with health services, and there's often a kind of motivation to think about changing lifestyles and things in their life that may help to support the health and well-being of themselves and their children. And in the UK, there's been routine inquiry about domestic violence across maternity services from about 2001. So of all of the health services, they're much more experienced in routinely asking women about their experiences of abuse. So what are independent domestic violence advisors, or as they're known kind of in the field, IDVAs? They are trained professionals who work with survivors of abuse to address their safety needs and to support them to reduce the risk of harm from intimate partners, ex-partners or family members. They generally come from the feminist third sector backgrounds, working in domestic abuse sectors, and they receive specific training from the Home Office to become accredited IDVA providers. They provide practical and emotional support to survivors, both men and women, but largely women. They can provide general advocacy support similar to what you might see in a mental health context, but also do specific things around the abuse, and maybe helping survivors with safety planning, supporting them through court processes, helping with key things like accommodation and financial support. And in the community, we see that they work with people on average for 2 to 3 months. So why are we doing this study? Well, there's increasing evidence now of the effectiveness of these models across health services, and that includes both primary care, acute health services, and some evidence in mental health. But we don't really know, there's not much known about how they operate and their successes, particularly in maternity services. But anecdotally, we're aware that many of the referrals that come to IDVAs when they're based in healthcare settings are from maternity services. We also, as many of you will be aware of, there's been big changes in maternity services during the COVID-19 pandemic. Now, I know there was services across healthcare, different healthcare services, but it had a particular impact on maternity services. And I can say that myself, as having my first son around the time of the first lockdown, had a big impact on my engagement with services and any check-ins and that I had. So we want to really look within this work to see whether that might have made, could have any impact on whether women are able to get access to IDVAs, if they're, depending on how much contact they're having with services, and whether it has an impact on the delivery of these models. Now, in 2020, the newly appointed UK Domestic Abuse Commissioner launched a toolkit guidance for healthcare services about how to best implement IDVA-based models in healthcare settings. It's a really valuable document, about 160 pages long, though. It's very high level, so there isn't a huge amount of detail on how to how services might address some of those issues that come up in the day-to-day implementation. And so we really want to try and explore that in this study. So what do we want to do? We want to identify and describe, as a very basic thing, where IDVA models exist across health services in England where they have maternity services. So there's actually been no mapping of where health services are, where IDVA models are based in health services. And that's because there is no kind of national funding for these programs, so people are getting local small-based funding sources, and there isn't really a national picture of that. So we've done a mapping exercise, which I'll present. Then we also want to get some information about what might be some of the key barriers and facilitators to implementation, and we did that through a World Cafe event, and I'll briefly highlight the findings of that. And in the last part of the study, we're doing a case study evaluation of 3 NHS trusts where they have IDVA models in their health service. And we want to understand how that model is doing with regards to increasing awareness and identification of domestic abuse among maternity service staff, and potentially increasing the number of referrals that women get to conferences that are specifically looking at reducing their level of risk around abuse. So this is our mapping exercise. Sorry, I don't know how much detail you can see here on the map, but essentially the blue spots are health NHS services where they don't have an IDVA model in place across England, and the red spots are where they do. So we approached all 124 NHS English trusts where they had maternity services to ask them to take part in the study, and 86 of them responded, which we were quite impressed with because we were running this over the winter period in COVID. Just over half of them had an IDVA programme, and generally there's quite a good spread across the country where there is some provision in most areas, but we do see some patches, particularly in kind of east of England and the Yorkshire area. We asked people whether their IDVA programmes are permanently funded or on fixed-term funding contracts, and the majority of them are on fixed-term contracts, which builds a question around the sustainability of these models going on. And generally, most of them just had one IDVA, so it's one worker trying to deliver support to survivors of abuse across the whole trust. And we thought it's important to try and identify the numbers because potentially there's quite a lot of load that they're trying to support there. And finally, I've just put in the slide here that it's about where IDVAs are physically based in the trust. So because they will be seconded or either contracted to spend from their third sector community domestic abuse service, we wanted to understand where they're actually doing their work from, because there is some data to suggest that it's really important for IDVAs to be physically based within the NHS trust so that their colleagues get to know who they are, they've got a contact number, they can approach them or they can pop into their office. And just over half of the services had the IDVA split their time between their community service and the hospital. With our World Cafe event, we did it was online event because of COVID restrictions. We brought together national stakeholders who have important insights into this area. We interviewed service users, staff, commissioners, people from the domestic abuse sector and policy advisors. And as I mentioned, we wanted to identify some of the barriers and facilitators to implementing this model in health services. With regards to enabling factors, so building the argument for having these models in health services, people talked about the need to have, for the local authority and the trust to be able to demonstrate a local need for this service. So maybe having figures on how many people coming through their service might be experiencing abuse, what do they know about the abuse levels in the general community. Another key part was to make sure that staff have training not just around domestic abuse, but also on who the IDVA is, what their role is, what their remit is, and so they can get awareness about what this model is and how they could refer to them. Key points for the IDVA when they were doing this role was to have active support from senior management in the trust and some trust governance of the model. So not just kind of being an intervention popped in with no kind of strategic oversight of it, helping to sort of have just both a bottom-up and a top-down kind of investment in the programme. They also talked about the importance of having regular structured support from both as clinical supervision for their role, but also having robust support from clinical and operational trust staff, That's helping them to understand the system that they're working in, how they can kind of operate and navigate and network with colleagues in the healthcare setting. With regards to challenging factors, and there's many more than I can present here, but just these are some of the key points. Some key practical things came up was some of the issues the IDVAs had was actually having access to a private space in which to meet with people and to discuss and conduct their work. So they just didn't have a physical space on site, and that then became very problematic for them. In certain areas, they also talked about they actually really struggled to appoint IDVAs from the community because there weren't enough available. There was discussion about whether the pay scales for IDVAs are maybe not reflective of the demands of the role, and so a lot of people are leaving the third sector and going elsewhere. But also that when they could appoint IDVAs, there's often a high turnover. And some discussion around that was perhaps the importance and value of ensuring that they have robust support and clinical supervision to manage the challenges of their role. Perfect, thank you. I'm just about to finish. I've already mentioned funding and the importance of trust-wide support. So just finally, what we're going to do with our case study evaluation, and we've just got through ethics and we're hoping to start in the new year. We're going to work with 3 trusts across England, one in the southwest, one in Cambridgeshire, and one in the northeast. And they're at different stages of the implementation of the IDVA model. The one in the southwest is just about to appoint an IDVA. The one in Cambridge has been doing this for a few years and is expanding their model. And the one in the northeast is moving to expand their program across different areas of the trust. It's a mixed methods case study evaluation, so we want to examine their documents on the program to understand what they're delivering, because we know there'll be variation. So for example, in one of the services, because of the restrictions of their funding, the IDVA's probably going to spend most of their time looking to raise awareness and training among staff of issues of domestic abuse. And maybe, sorry, I said that wrong. They're going to spend most of their time working with survivors of abuse and won't have much time to do work around training and supporting staff in identifying and knowing how to respond. Whereas for other programs that have a bit more funding, they can do both of those roles. We're going to be, in order to map some of the implementation activities as they go along, we're going to be checking in with staff regularly, maybe twice a month, to see what's happening as they go in time, when challenges come up, how they've addressed them. And we'll also do qualitative interviews and service users, and surveys with staff and service users to get their impressions of the experience of the case study. So this will be running till September next year, and we're hoping that at the end of the project we'll be able to develop a set of guidance around, more specifically around with the detail on how staff can overcome and challenges that come up in implementing the program, understanding particularly having better guidance for how these services can work most effectively with maternity services, who are often the highest service for referrals. And I'll stop there. Thank you.